Good morning, everyone. First, let me thank CARPHA for the opportunity to share some of what we've been doing in Dominica, our experience with respect to chikungunya. I think most of us in the room would have had some exposure to the challenge, and I think it's important that we share in order to make our interventions better in the subsequent interactions with the virus. So we'll talk a little bit about the timeline of the epidemic, some of the surveillance strategies that we used, some of the data, public health response, lessons learned, and some of the next steps as we see going forward from this point. So before I get into the presentation, just to remind especially the colleagues who are not so familiar with the Caribbean, that Dominica is actually the Commonwealth of Dominica, and is located in the Eastern Caribbean chain of islands, the northernmost of the Windward Islands, and was sometimes confused with the Dominican Republic, or República Dominicana. And also on this map is important to know the location of St. Martin with relation to Dominica. And of course you can see all our islands are very close, and there's a lot of movement between countries. So when there's an outbreak in one country, it's just a matter of time. So talking about time, our first suspect case was actually December 20, or the 20th of December 2013, which was right after the outbreak was declared in St. Martin. An astute clinician, district medical officer, having heard the alert that we put out in the local healthcare system, suspected the case based on the travel history. Patient presented with fever, female patient, middle-aged, presented with fever and joint pains. And so the patient was sampled and the specimens were sent to CARPHA. On January 15, the results came back positive from CARPHA. And that, of course, triggered a public health response investigation looking for contacts and possible hidden cases. And of course, also to begin the vector control activities. And this effort actually revealed a number of cases that had not presented to the healthcare system. And especially when we went right to the press once we got confirmation, and as I said, 3 other cases were sampled in the north of the island, and they came back positive, and thus confirming that we had our first case or cases of autonomous transmission by the 28th of January. So, as I was saying, the autonomous case had no travel history, by definition, and the fact that we were finding other cases who were ill at home suggested that the transmission was actually ongoing prior to the identification of the first case from St. Martin. Our investigations suggested that there was movement of hucksters or informal traders between our countries, particularly between the French islands and Dominica. And we think that's probably how some of the first cases actually came in to the country. So having confirmed autonomous transmission, we convened our first national stakeholders meeting on January 30th, within 2 days of the confirmation. And by February 8th, one of my colleagues from Yale University, Professor Derland Fish, who had done extensive work on entomological work on Dominica, volunteered and came in to see how he could help with the mosquito or the vector control effort. Following Derland's arrival on the February 10th, Ms. Thais dos Santos, the communicable disease advisor from PAHO, arrived, and we began putting in place the mechanisms for data management So while Durham was focused on vector control, we then began looking at managing the data, ensuring that the clinicians or the public health staff were aware of the case definitions, etc., and reporting we need to report. On February 17, the big team arrived from CARPHA, Dr. Hospitalis, Dr. Olokore, Dr. Paulson Edwards, and Ms. Lorraine Francis. And they also gave us a huge support in actually doing some of the field work, field investigations, looking at the entomological situation. And I have to say that the support that we received from these three groups was really essential in enabling us to manage the situation, which, as you will see in a minute, kind of exploded before our very eyes. Luckily also, I had a few overseas volunteers working with the Health Information Unit at that time. So, and I'm happy to report that almost a year later to the date of CARPHA arriving, we were able to declare that the epidemic was officially over at the end of last week. And you'll see the epidemic curve in a minute. So the case definitions that we use, of course, were taken from the manual, the guidelines developed by CDC and PAHO. Note that the initial guidelines suggested that you had to have a travel history. And once we identified that there was autonomous transmission, then we changed the case definition to with or without a history of travel. Person presenting with fever and high fever and arthralgia or arthritis. And of course, confirmed cases were from CARPHA through PCR testing. So this is how the island is divided. You'll see that most of the population resides around the coastal areas. The country is divided into 7 health districts, and the information flow follows this pattern. So in each health district, there's a consolidation of the data, and then each district then reports in to central level, the Health Information Unit, which collates the national picture. So we, as I said, developed our case reporting forms, ensured, and we did active surveillance, of course, so each day, we went into daily reporting. Each day, we had to call each of the reporting sites and collate a daily report, and then we called people together to train, and then we had a more in-depth report on a bi-weekly basis initially. We had a database which we created in EpiInfo, and as you see, this is an example of the report that was being put out. This is a weekly report, but a daily report. And the purpose of those reports was essentially to flag some of the key issues, key challenges that we were having in managing the epidemic as we went along, and to keep people informed. As the epidemic progressed, we became really overwhelmed and we couldn't maintain the daily reporting. So we maintained a comprehensive weekly report that kept all the stakeholders informed. And then surveillance, all of this data was discussed at the weekly surveillance meeting. Since 2004, syndromic surveillance is in place in Dominica with a weekly review of all the data, and it's a multi-sectoral, multidisciplinary meeting. So and not only exclusive to health. So we have other stakeholders who attend that meeting. And so that's where a lot of the decision making was taking place. So this is the epidemic curve. As you can see, we had pretty intense transmission between March and to the end of June. There were 3,771 cases reported, and of that, 4.6% were confirmed through CARIC. That gives you an attack rate of 5.3%, but we know that this is an underestimate because we know that, number one, not all cases are reported to healthcare facilities, and there's also limited reporting from the private sector. In terms of the demographics, similar to what we saw earlier, the main age groups affected were between 10 and about 49 years, so the school age and working age group. And interestingly, we had almost equal male and females, 57.8% female compared to 42% male. This diagram shows you the incidence rates by health district. So the north of the island, where the first cases were identified, had the highest incidence rates in the country. And this diagram gives you the timeline of the epidemic. You can see how all the villages, all the areas were residential areas were eventually affected by the epidemic, with the north of the island and around the capital having the majority of cases. Most people presented with fever and joint pains. And in terms of hospitalized patients, about 50% of cases, with 112 hospitalizations, and about half of those were under the age of 5. Most people were not severe and were discharged in less than 72 hours. Only 5.3% remained in hospital beyond that. And there were a few comorbidities. One patient with breast cancer, 1 or 2 patients with diabetes, hypertension. And so the public health response included preventing infection, being bitten by mosquitoes, and preventing infectious individuals being bitten by uninfected mosquitoes, which involved protection of skin using mosquito repellents. We actually distributed repellent to the healthcare providers, and then preventing using mosquito nets. And as you heard before, we had treated nets arrive courtesy of CARPHA to help to treat or protect or to nurse people who were identified as being positive. The vector control response included fogging and in some instances indoor residual spraying, and I look forward to the discussion on that one, IRS versus fogging. And we targeted the areas that we had new cases, as well as those areas with high mosquito indices that we had from our regular vector surveillance. Case investigation of premises and source reduction activities, which included community mobilization for cleanup campaigns. And we did collect some GIS data on several of the early cases. We also set up an entomological lab. We collected eggs that were sent to CARPHA for insecticide sensitivity. And we also found that permethrin that we were using was the mosquitoes were actually resistant. So we switched to 5% malathion based on that information. So thanks again to CARPHA for helping to guide that one. Risk communication included production of posters, PSAs for radio, television, pamphlets, alert cards at the airports. We used the CARPHA chart here and circulated that through the school children into the homes to remind people about the cleanup and source reduction. Pamphlets, as you can see here. Graphics were on display in business places at the points of entry, electronic notice boards, as well as paper, television, talk shows, mass text messaging, and media communication as press conferences and print and internet media. And of course, community meetings. And here you see a politician, this is a member of parliament for this particular area, being involved because we had, partway through the epidemic, we had to start dealing with the issue of rumors. The fact that people were saying that this, like we heard earlier, that this could not be due to a mosquito, this must be some other problem. And so we had to jump on that one pretty strongly. As I mentioned, health education. Oops, backwards. Right, and here you see a list of all our stakeholders: Ministry of Finance, Tourism, Education, Hotel Association, and so forth. And just to wrap up, some of the key lessons learned. you need to have early planning and rapid mobilization of resources. This is critical. I think the availability of external technical experts to support small island states in particular in situations like this is crucial. And the mobilization of resources for implementation of the response is also critical. So the question of whether we should be looking at having small regional stockpiles that can be mobilized to assist countries rapidly to try to break the chain of transmission early before it gets out of hand. Highly sensitive case definitions. The fact that we may have missed the boat because we insisted on a travel history before we would test. Rapid dissemination of information to the relevant stakeholders and to the public, and using the information to guide interventions. So knowing where your cases are occurring, knowing where your high vector indices are, can help to target the program of intervention. And surveillance of insecticide resistance proved to be very, very critical. So next steps include survey of chronic symptoms. We are thinking about possible telephone survey along with other countries. I think the protocol for this should be standardized so that we can compare data across countries. Possibility of a prevalence survey to confirm what was the extent of infection in the country, and a more formal economic impact study would be quite useful and maybe helpful in mobilizing in-country and regional resources towards vector control. Really, again, I'd like to thank all the colleagues, the partners who helped us in a very difficult time. Remember, this was just before Ebola, all the Ebola threat and all of that stress that came with that. So very, very important to have support from regional agencies. Thank you very much.